Okay.
She's a 50-year-old female. She is known diabetic for the last 20 years. She is using oral hypoglycemics for that, and she is hypertensive. 12 years back, she had a thyroid surgery. For that, we have no documentations. But after that, she says she was using some pill which doctor said her that it is necessary for you, and so I assume that would be thyroxine. So patient presented with the complaint of shortness of breath and productive cough for the last 1 week.
And this is for the first time he had any cardiac issue.
Yes, she has
Her
never
background
been
is hypertension, diabetes, and some
surgery.
thyroid issue, a surgery done. After that, the surgery was done when?
12 years back.
12 years back. And after that, she was put on thyroxine probably, because this the drug commonly.
So
and for 1 day she had this shortness of breath.
For 1 week.
1 week.
She has been having this shortness of breath for the last 6-7 years.
Okay.
And she was referred to an SAVD by some other doctor, local physician. And she had shortness of breath and productive cough for the last 1 week with a function class of 3 to 4. And she was interpreted as N-STEMI ACS.
That must be, she had ECG and troponin and all the things.
Troponins were...
Because you have, right now you have missed 2-3 steps. After shortness of breath history, I need preliminary investigations. And in a cardiac unit must be an ECG and then troponin, because non-ST straight away means that you already have given me diagnosis. After history, directly troponin biochemistry.
In the prior hospital, she was interpreted as a cardiac
even in
case, and then
prior hospital, she must had an ECG prior to troponin.
Yes.
But that ECG was
the
showing.
ECG was normal sinus rhythm with there were no ST elevations, but they have interpreted that as STEMI or non-STEMI.
But ECG wasn't showing any clear-cut evidence.
Yes.
But now this case would be like this, that this patient had a very strong background in a way that long-standing diabetic, hypertensive with hypothyroidism. So he went somewhere with SOB, which was aggravated with pre-existing status. With even ECG which wasn't showing any significant changes, but they consider her to be ACS. Because ECG is not showing if ST elevation or rapid ST depression, you still consider this patient as definite ACS or high risk probable ACS. Because if symptoms are not clear-cut chest pain, just SOB, it can be other things as well. But then troponin, what was the level of troponin there?
The first troponin was 0.06 and the second was 0.09. And shortness of breath, she had never had any episode of chest pain.
Okay.
So
again a borderline troponin.
Yes.
So it's not a clear-cut raised troponin. Now again with borderline troponin, you have multiple reasons. We are just now discussing pulmonary embolism as well. People miss pulmonary embolism because of slightly increased troponin and considering ACS. And just treating ACS and discharging with thallium and others. Without yeah, if they have raised troponin. So even with this troponin, are you sure that this is non-ST elevation?
No, I've just...
What your consideration, considering history, everything and further workup? Do we have any further workup after that troponin?
We have planned echo. First,
so then what is your suspicion? Still a definite ACS or a probable ACS?
My suspicion is probable ACS.
You still considering?
Maybe she can have ACS.
If that is a probable ACS, then you have to think of a cause of SOB with aggravating status right now. So what's the alternative in your mind? If probable ACS, then what is the alternative?
My thinking is most of the time on pulmonary side. She must be having some pulmonary issue in the background, because she is giving some history, some sort of domestic birds and biomass exposure.
You are thinking of interstitial lung disease or something of that kind. Some chronic pulmonary diseases, either COPD or interstitial. Okay, we'll go in that way. So echo will guide us towards, because if cor pulmonale, RV and do we have any evidence in ECG? In ECG and X-ray will give you some hints towards your suspicions.
On X-ray, we have
Any important thing you can do in biochemistry with this query of pulmonary and because you have a query that this is a cardiac pulmonary edema or a pure lung disease with a background of both diabetic, hypertensive, ECG isn't showing anything significant. Anything you can do?
in biochemistry, we can have
ProBNP level.
Very good. Anti-BroBNP. That would be more appropriate. Pro-BNP is available for a slight time, small. So anti-BroBNP would be inappropriate to do in this patient. To give you an idea, is it a pulmonary edema or a predominantly lung issue? It can be raised in lungs as well, but there are levels on which you can at least, on that you can judge. So this is a patient which we need to work up further. Echo, is it available here or no? Oh, but it's expensive. I think it's worth to do in this
We can
patient.
do inflammatory markers as well,
But they are not definitive. CRP and other things, they won't give you right answer. But this now anti-BroBNP is an algorithm of heart failure. If you are suspecting a case of heart failure prior to echo, you should be doing anti-BroBNP. If it's normal, your heart failure is excluded. So this is a classical case for that, anti-BroBNP. Okay, so get an echo and other.